I'm Richard Walker, Executive Director of the Benjamin Rush Institute. We hope you enjoy today's edition of the Benjamin Rush Institute's virtual events series. This series would not be possible without the support of foundations that endorse the mission of the Benjamin Rush Institute, our student chapter members, and individuals like you. Through your support, we are able to continue informing and educating today's medical students about the benefits of patient-centered, doctor-focused methods for the practice of medicine, just like those discussed in this series. I encourage you to visit our website to learn more about the Benjamin Rush Institute and the medical students we serve. While you're there, please consider a donation to support our educational programs and events just like this one. You can donate by card, check, or by mail. Thanks for your support, and thanks for watching the Benjamin Rush Institute's virtual events series.
I want to thank everyone for joining us today. Welcome back to Benjamin Rush Institute's virtual event series. My name is Rebecca Kiesling, and I am BRI's Director of Programs. Great to see so many people here today. We have students, physicians, we have some supporters that have been to almost every single one of our virtual event series, so I thank you all for joining us. As I mentioned, we are streaming across a number of different social media platforms, so please ask your questions. You can ask them in any of the chat groups that are available via social media. If you are not familiar with the Benjamin Rush Institute, we are a 10-year-old association, and our mission is to further the doctor-patient relationship, and we do that by educating medical students across the country on free market healthcare alternatives that they just aren't receiving in medical school, primarily because medical schools are funded by big business, by big pharma, by big insurance, and the education that they are receiving just isn't about free market healthcare and the alternatives that are available to them. We have had the opportunity to speak with many amazing practicing direct pay physicians during this series. We've heard from direct primary care doctors, including those on the front lines of advocating for changes to policy on the state and national levels. We've spoken to doctors working to ensure that your care comes from a doctor, not someone less trained, and that you have a choice in that care. We've heard from direct pay specialists providing fee-for-service care that takes insurance and big business out of the healthcare equation. And that has been wonderful in this series. Today, I'm excited to speak to a man on another side of this fantastic healthcare model, one that's working to preserve the doctor-patient relationship while helping physicians to grow their businesses. I met Christopher Habig at the DPC conference in Orlando a couple of years ago and was really struck by his passion on furthering our mission. I've had the opportunity to chat with him on his podcast, Healthcare Americana, which I hope you will all subscribe to, and am looking forward to speaking with him here today. Christopher has been active across a wide range of functions and industries during his career. He developed his personal style of leadership to drive forward company visions, missions, and strategies, and is really skilled at bringing the concepts to life and into the market. Even though he earned his pre-med coursework and probably disappointed his parents, he got a BS in finance at Butler University. He became a partner with a real estate investment property management firm and earned his MBA at Indiana University's Kelley School of Business. After leaving the real estate management company, he really turned his focus back to his passion, and Chris was a co-founder of where he currently is at Freedom Healthworks. Chris and Freedom Healthworks really move forward and ensures the progress in key performance areas while adhering to the company's core values. And I hope that Chris talks about what Freedom Healthworks does throughout our industry and really helping businesses. He works to expand Freedom's presence in the industry, working with like-minded people to help the company continue to change the way American healthcare is delivered. I've really enjoyed getting to know Chris, getting to know what his company is doing, and listening to what Healthcare Americana is doing to further what our whole industry is doing and our whole mission. So I am going to, you're not here to listen to me. This is a really interesting topic, and I'm talking to our students here because one of the things that we talk about, all our students talk about a lot, is that you're not getting a lot of the business acumen that you really need to move into your professions. Christopher is wonderful. He has that knowledge. His business helps doctors in the direct primary care industry with that knowledge that they need. So take this, listen to him, and we are going to let Christopher talk, and then I'm going to jump back in. Chris said he's used to the podcast format, so we'll get back to that in a little bit. So ask your questions, and I'm going to turn this over to Christopher now.
Hi, everybody. Rebecca, thanks for the intro. Gosh, hope I can fill the shoes of whoever you were talking about there. But thanks for having us. And like I said, like Rebecca said, I'm very used to doing podcasts. We've been doing podcasts for about a year now to tell a lot of the stories that we run into. So with Freedom Healthworks, we call ourselves a direct care accelerator. So we are in direct primary care. And I know you've talked to a good number of doctors and advocates of the DPC model throughout this virtual series. And, it's nice to go through that roster and be like, oh, wow, these people have told a lot of stories and really connected with people emotionally. So that's what we do on our podcast, Healthcare Americana. Under Freedom Healthworks, like I said, we want to accelerate the movement. So we are here to help physicians exit the employed world, start up, spool up their own independent direct primary care practices, and even working with some specialists to get into what we call direct care. So we drop the primary from that and let them go into direct care. And that's really been our passion for the past few years. And like you said, I decided not to go to medical school. So a little bit about me. I graduated right when the ACA passed from undergrad. And I talked to my parents who are both practicing physicians in the DPC model right now. Talked to a lot of family friends, talked to a lot of people who said, Chris, don't do it. Don't go to medical school, go to law school, go to business school. And I said, why? Why are everybody that I know in medicine saying, don't go be a doctor, don't follow, what I grew up experiencing? I mean, every day after school, I was in my dad's office talking to patients, talking with the nurses. They were like a family to me. And to hear somebody say, don't go be a doctor was very, very powerful. And you take that advice, right? You kind of took it to heart. And so I went into business instead, and with an eye into medical care, actual Medicare, not just what we term as healthcare out there, and decided to attack it from the business perspective. And so a lot of personal things happened that delivered us here, with family members getting sick and really emphasizing the need for a doctor-patient relationship. And without a doctor-patient relationship, I would have lost a lot of loved ones very early, not necessarily to negligent or poor medical care, but to physicians who were far too overworked and far too hurried to make an accurate, clear decision. And digging a little deeper, there were a lot of factors behind that. And these physicians were not free to make their own decisions. And when that happens, when you have somebody looking over their shoulders constantly, that becomes an issue, whether they are employers, hospital administrators, big network executives, or even insurance companies. And so that's why we came, how we came into Freedom Healthworks. One of our big mottos, and we have printed up t-shirts that say this, is that insurance does not equal healthcare. And so that's a theme that's been kind of co-opted and perverted over the past 10 years or 12 years or so. When you talk about healthcare reform from the federal level, a lot of people are just talking about reforming health insurance or the way that health insurance or coverage is paid for. What we wanted to talk about and get back to was the actual interaction between a physician and between a patient, because that is what healthcare is. That's true medical care. And so when I was invited to partake in the series here, we thought, what an interesting topic, that how to extract people from employed situations where they might dangle big signing bonuses in front of you or lock you into long-term contracts, throw some non-competes, and then people end up being just absolutely miserable. The biggest growth that we see from our clients are physicians who are 2-3 years out of residency. They get into hospital systems, they get into the big networks, and they realize this is not why I came to medical school. This is not why I became a physician. This is going against it. I wanted to take care of people, and now all I'm doing is basically working in a factory with an RVU factory, as one of my podcast guests called it, and just seeing as many patients as I can during a day. And to a lot of these physicians who go into the DPC route, that's not why they wanted to do this. So that's why I wanted to focus this talk, kind of the benefits of an independent physician versus the employed model. And I did a podcast last week and was doing some research on it. And from national polls, I found that less than a quarter of medical students today say they plan on owning a practice in the future. And it's kind of disheartening from my side, obviously, because we work with independent practices, but to watch what has happened within the industry in the past little over a decade and watch these roll-ups of small independent physicians in rural areas, in urban areas, and watch these hospital systems do this to physicians and then ultimately disrupt that continuity of care. Patients are out of options in a lot of areas. And what it does is it drives anti-competitive behavior. Prices, if you can find them, skyrocket. And there's nobody who can actually give you a full quote on prices. So there's a lot of things that stem from consolidation within the market. And I was trying to find it, and I'll have to do a little bit more research here last minute. But one of the authors of the ACA actually came out in the Wall Street Journal and said, we missed the mark on this because we thought the innovation would be found in creating economies of scale in big hospital systems, when in reality, it's the independent physicians who are so flexible enough that they are able to tailor care the way that their patients need it, and not have to go through the red tape and the bureaucracies that a lot of the hospital systems create. So that's a little bit of the background, and then what we're talking about here today. And please, we have a ton of time for Q&A. So again, I love that back and forth element through these types of conversations. But just going a little bit further into why we're such big fans of independent care versus employers. Basic business function here is that a lower overhead will equal a lower cost. And again, this is what we're seeing in DPC and within independent physicians' practices. I mentioned the fact that hospitals cannot quote a price for anything, even though they are legally obligated to at this point in time. We're in Indianapolis, Indiana. In Indiana, they are legally obligated to publish these prices. Again, the federal level, they're trying to pass some legislation. They're being fought tooth and nail. And I know that you've had some guests on here talking about different legislation from that and why hospitals and insurance companies would be fighting price transparency. It just doesn't add up, But a lot of these hospital systems will treat physicians like they're complete morons. And there's no way to sugarcoat it. They say, hey, doctor, all you're good for, after all your experience, and you're obviously one of the more brilliant members of society here, all you can do is just go in and take care of patients. And oh, by the way, you only have 7 minutes to do that. No other industry in the world functions like that. At last calculation, we found that there's 16 hospital administrators for every physician in any given hospital system. In primary care offices that work with insurance, usually that's about 5 or 6 full-time employees per physician. And this is something I just shake my head at, because that is a massive amount of overhead for one person to be supporting. And all that support comes within the encounter between one patient and one doctor. So there's a lot of hands in the pie if anybody's able to even quote you a price. In a typical DPC practice or even an independent practice that accepts insurance, DPCs are either the doctor only running that practice or working a ratio that's about 1-to-1. So one full-time employee versus one physician. That's a little bit better because you have a support staff and then you have the physician out there taking care of people and earning revenue. I do want to say that I don't want to come across as everything a physician does is revenue based. I know a lot of critics might hone in on that, saying, physicians are supposed to just focus on getting people healthy and taking care of them. But the crushing burden of an administrative just bloat weighs heavily. And then that's where you get things like RVU factories, or one of these more sad stories that we came across was a physician who was the head of the residency department at a major teaching hospital here in town. And she submitted her resignation one day because she was overseeing some resident physicians, and some admins came down, pulled them into a conference room, and started absolutely berating the resident, saying, and the gist of it was that you are taking too long to see patients. And I just want to let that sink in, that, put yourself in a patient's shoe, or, maybe you've seen this if you're doing rounds, getting yelled at because you're providing too good of care. You're caring too much. You want to answer all the questions to a patient. And then your boss or somebody you even know who might be above you in some C-suite in some hospital coming down saying, you need to spend less time with these people. I mean, that's incredible. And that is leading to massive frustration. People use the term burnout a lot. I think burnout doesn't do justice to what a lot of physicians in this setting are experiencing. It's almost like an emotional kind of assault, an abuse, if you will, that physicians have to encounter day in, day out, because a lot of them there's a lot expected of them, and to not be able to follow their passion, follow their career, and take care of people the way that they are experienced and the way that they know works. That's tough, for anybody, whether you are a secretary, a clerk, or anything like that. No matter what you do, to be able to go out and exercise your passion is going to be a major motivating force. Another thing I wanted to talk about was referrals. Now, it's technically illegal to mandate that referrals all stay within one hospital system, but it's kind of an unspoken rule that happens. And, anecdotally, and I've looked up a couple of different rates, but they're putting in the 90% rate there, where cases from a primary care level or even for a specialist level are referred to the same hospital network. It's not supposed to happen. It's very anti-competitive and therefore very much against the law to entice physicians to do that or mandate that physicians do that. But again, in the conversations that we've had, talked to a very accomplished orthopedic surgeon, and he said, Chris, I was mandated by the end of my career that 1/3 of the people who walk into my office for evaluation, okay, 1 out of every 3 people, I have to send them into surgery no matter if they need it or not. Whether they need just therapy, whether they can get by with DMEs, 1/3 of those people, the business model was built on sending them into surgery. And again, he shortly left after that for taking too much time with patients and trying to provide enough care that didn't fit the revenue model that the hospital was espousing. These are very real stories, right? These are real lives. And we can see this within COVID big time. Look at what happened to hospital systems when primary care offices shut down. So to take a step back, primary care offices, they had to see patients in person, right? When that doesn't happen anymore, primary care offices are shut down. I kind of feel bad saying this, but the pandemic was very good for business because a lot of experienced physicians were fired or let go because they weren't seeing people in office and they didn't have the communications technology capabilities to provide what we now call telehealth. And so when those primary care referrals dried up, the elective surgeries in the hospital dried up. The specialist visits in the hospital dried up. Some hospital systems lost close to 60% of their revenue, and it was all based off of these referral channels. And so there's definitely real pressure that exists in these hospitals to keep it in-house. And that's why a lot of hospital systems do take a loss on primary care, because they know there's a certain volume of basically triaged patients have to come up into their system. The primary care physician does not have enough time to spend with patients. Therefore, they're going to order a battery of tests, a litany of imaging, and see if anything sticks. If not, see you in 3 weeks. So this kind of leads me to my next point here, that independent physicians are able to find the best physicians, the best specialists, the best referrals anywhere out there. There is no conflict of interest, right? So put yourself in the patient's shoes. If you're a patient and you go to the doctor, something's wrong, and they refer a surgery to you and then send you down to the same hospital system, is that physician acting on your best behalf? I like to think that the answer is going to be yes. Overwhelmingly, every single time, the answer is absolutely yes. But what if you want a second opinion? Are you going to go see the same network physician, or are you going to go somewhere else? With an independent doctor, as an independent doctor, I should say, you can refer to the best people around you no matter what. You have all the power back into your hands that you and your patient can make the best decision possible. Best decision for any type of catastrophic coverage, best financial coverage, best care coverage. Domestic medical tourism becomes a very real thing. And then that's where you can find the best quality surgeons, best quality surgery centers, travel plans. And again, going back to the financial angle, able to quote them a price, figure that out, and then they can make the best decision for you. So your patients do become more educated healthcare consumers, which is a whole nother thing in itself, right? Most of American industry tries to make it very, very easy for people to find out information about their products. They usually bombard you with this information to try to get you to make buying decisions. Not so much within healthcare. Everything is kind of smoke and mirrors and hide the 8 ball, kind of the rotating cup game. And when you're a patient and you walk into some place and you're like, hey, I need to know what your quality scores are. How you define quality is also a very good question, because most quality decisions and most quality metrics are whatever the government, CMS, or insurance companies say quality means. So again, a lot of shifting goalposts there that make it very tough for the doctors out there and the future doctors out there to really make the best decisions for themselves, for their practice, and for your patients. Another thing I wanted to talk about was, I touched upon the continuity of care earlier, excuse me, but you get to know your patients better. A lot of insurance companies will treat physicians just as a roster or a list of names on a website or on a paper form mailed in. And that's tough to make any type of decision. It really is from a patient standpoint, and it dehumanizes the physician. So one thing that we're always about from our company standpoint is really humanizing healthcare. Physicians, if you have a stethoscope and a white coat, you're all different. Everybody has a little bit different philosophy, a little bit different bedside manner. But when you're treated as commodities and saying that physicians, MDs, DOs are no different than each other, and here's a list of people, start calling and just figure out where you can get in first. And then now it's even more tough and more hard to swallow is a lot of these systems and insurance companies are replacing physicians with nurse practitioners and PAs. There are very important roles that NPs and PAs occupy and that they play. Replacing MDs and replacing DOs, the expertise that you have during medical school and during residency, that is very scary to me as a patient, and to me working with a lot of physicians out there. There's a lot of scary things that could happen when you take somebody who's very experienced and insert somebody with maybe 10% of the training into that decision. It just seems like a very big recipe for disaster, especially when we're dealing with the pandemic. We're dealing with opioid epidemics, looking at prescription rates from mid-levels. I mean, all of this stuff plays in and on itself. So that brings me to this point where you get to know your patients better. As an independent physician, you're going to form relationships with your patients, with their families. You're going to learn their history, and you're going to have time to sit down with them and get this all on paper, make sure the charts are correct. It drives me nuts when, for instance, my wife and I just had our first child, had our first daughter, first baby 2 months ago. And I was kind of the problem patient in there because I was constantly asking to see the chart because a lot of that stuff is just hidden. And I'm coming from it from the standpoint that I want to make sure all the information is correct. We didn't miss any allergies. We didn't miss any test results. Something wasn't keyed in erroneously. And if people aren't experienced enough to ask those decisions and not comfortable enough to form that type of relationship and teamwork with a physician, a lot of things impact that care. We're seeing a lot of issues with physician non-competes from these employed systems as well. And again, going back to patient well-being and the continuity of care, and hopefully there's some physicians out there who've gone through this, unfortunately, and they might be able to attest this or it speaks to them. But when you put notice in that you're going to leave your employer or your hospital system, they act like you just disappeared and dropped off the face of the earth. And we see it time and time again as we start to help doctors start up their DPC practices. But they have a duty to inform. Physicians have a duty to inform their patients that they're going elsewhere. And when they put in their notice, the hospitals throw a lot of non-competes at them, and they don't tell patients where they're going. And so we've seen some non-competes that are they're like 25 miles away from any location in a health system. And it's kind of frustrating, very kind of laughable and mind-boggling of why this would happen, because you're basically saying that you need to move to a different state or a different part of the state completely if you wanted to continue being a doctor. Now, most of the physicians I've ever encountered, medicine is a calling. Healthcare is not a career. It's a calling. It's in their DNA. It's what they want to do. It's their life purpose. And for some administrator, some employer saying, you know what, you want to go independent or you want to go work for somebody else, great. But you're going to have to pack up, uproot everything and go out there and do that. You can't just walk across the hall. So there's a lot of issues along that, but tying back into the continuity of care and then developing that relationship with patients a little bit more. And then kind of my last point here, and I've touched upon this throughout, is that administrative burden, administrative interference, as we'll call it. Again, we've seen this during the pandemic. Stories abound of hospital administrators forcing physicians and forcing nurses just to put COVID down on any type of patient chart because the reimbursements were actually higher within that. And there's a lot of stories back and forth. And again, this is more anecdotal, kind of sharing some of the stories that we've seen from that struggle is, are hospitals and the admins going to make the best decision based on that patient and based on that physician input? And then going back to what I said earlier about how physician offices really dried up, and if somebody wasn't seeing anybody in person, then there was no revenue, there was no reimbursement, and how telehealth became kind of this big, kind of this savior of medicine. And we just kind of laughed about it thinking, you know what, this is something that is core to any independent practice, is that it is a phone call with a patient. All right. That's all telehealth is. And so we laugh about it saying, if you ever called your attorney or you called your accountant or you called your plumber and said, hey, something is wrong here, or I want to ask about my taxes, or what should I do with this? I want to buy a new property. We don't call that teleaccounting. We don't call it telelaw. We don't call it teleplumbing. Why do we call this telehealth? And I think the answer lies in the fact that healthcare and what we have as far as insurance-dominated systems and hospital-dominated systems is such an antiquated system that we are burdening physicians from even being able to build a business and build relationships with phone calls or video messages, a technology that has been around for 20-some years. Whenever Skype was first unleashed upon the world, telehealth could have started with that, right? You could have just had a video chat with the doctor, but the reimbursement and the innovation within healthcare was so far behind that it took a global pandemic for people to realize that there is technology that is older than some med students out there that is already able to perform these capabilities. And then we have, CMS writing new laws and legislation or suspending other regulations and restrictions because of this. And, it's something you kind of laugh about, but you shake your head thinking, wow, I guess I don't call it teleaccounting. I just call my accountant and he builds that into his pricing. And it's just like, why are physicians so burdened by this entire system that it's even hard to break free? So, I get it, and kind of been looking forward to the Q&A here. Hopefully we have a lot of good questions coming in here, but trying to establish the bright line that being employed, why it might sound great right out of medical school, you're earning your first big dollars. There's a lot of stipulations that come with that. And there's a lot of handcuffs, unfortunately, that happen because you cannot be the physician that you want. You cannot take the amount of time with patients that you want, that you believe is ideal. You can't sit down with families and get the entire environment and the entire ecosystem there. In a lot of this patient care, and especially within the quality and keeping people healthy, it has to come from an independent practice standpoint. So that leads into physicians as business owners. And to some, that could be a very, very scary, anxiety-driven type of situation. I know, again, last time I checked that most physicians have about 5 hours of business education through undergraduate and through graduate school and medical school. And, that's tough. It really, really is. But every single person I've ever met in the medical field has been super intelligent, and you don't have to do it alone. If you decide that you wanted to do your own practice, there are organizations such as Freedom that exist out there that have physicians' best interests in mind. And there's a lot of cool things you can do that don't concern going back and getting an MBA or anything along those lines. While it could be a complicated, scary process, just look at it as, at the end of this, I will come out better. I will be able to provide better care for my patients, build those better relationships up for it. And there's not going to be anybody over my back, either holding a bonus over my head or pulling me in different rooms and telling me to spend less time with patients, because that's only going to lead to more frustration. And frankly, we need all the physicians we can get. We need all the experienced, passionate people out there that we can get, and to stay in medicine, learn, get that experience up, and take care of all of us. Speaking as a new father, I really mean that. I want to make sure that there's a lot of great physicians out there when my little girl comes of age. And then as I age too, from a selfish standpoint, as a personal standpoint, that I want to make sure that there are physicians, good physicians out there willing to take time with me, who are not beholden to insurance companies, who are not beholden to some other administrative burden out there. So with that, I'm going to open up Q&A, Rebecca. So hopefully we got some good questions here. And this is something where people can kind of generate more thoughts of and get the wheels turning, and hopefully create some great dialogue down the road.
You brought up I know why we get along, because we are very much alike in doing what we do and the reasons behind it. Because, we talk about keeping physicians in the workplace and making sure that they have really they understand that there are other places that they can do the good work that they want to do. I have some students that right now that are texting me because they are chapter leaders at one of our chapters in Wisconsin, and they are looking at doing. There's two. They're co-chapter leaders, and they are looking at doing primary care. And what they are texting me, what Parker said is, you said that one of your biggest growing fields is student residents coming out of residency, being out of residency for a couple of years. So he wants to know, what is that process? What would that look like for those? How would you bring them in, and what would it look like for him?
Yeah. So if you're interested in the DPC world, there's a lot of cool things we can do out there. And so a lot of people look at, well, this is going to be a lot of money, and it really is not. I mean, starting a DPC practice, you are going to have some type of investment through that, but it is very, very low. We work with physicians who started their practice up for, less than $5,000. and they're seeing patients and really becoming a part of the community. One of the clients I'm super proud about, he's in Minneapolis, and he launched right when the riots were happening in Minneapolis. And he was in downtown. And so, you know what he did? He went out and we helped him print up a banner kind of in the middle of the night, and worked with the local FedEx store up there to get business cards, brochures. And he went out and we're taking care of first responders and people who were injured in the violence. And this is the kind of connection to a community that, again, you can do. It's kind of like the Norman Rockwell, where he did the painting of the doctor coming over, doing house calls and then putting his stethoscope to the girl's little teddy bear. That is actually real. People are doing house calls. And so, kind of roundabout way to answer this question, research your DPC options, and it's a lot lower than you anticipate. But one thing I always just emphasize is you have to be active within your community. And if you expect to just sit behind a desk and put up a sign and people start walking in, might not be the best fit for you. There are different ways you could go about this, but it is, again, taking care of patients, meeting patients where they really are. And then if the question is more along the lines of, hey, I'm in an employment contract, or I'm a resident and I'm looking at getting my first job, how do I find somebody who's independent, or how do I start up right away? Process is very similar to starting up their own practice. It really is. It just depends. I know a lot of people are in different types of financial situations, and it might come down to the fact that you might have a couple kids or little ones at home and unable to invest in your own business right now. And if that's it, then it's like, okay, just make sure you read your contract. Don't sign anything long-term. Make sure there's no non-compete in it, and make sure there's a lot of good out clause. Everything in contract is a negotiation. It really is. But if they would like more information about DPC, check us out at freedomhealthworks.com. Rebecca, you're more than welcome to share my email with them. Absolutely. And we can follow up with them. Not a problem. We like talking to anybody and everybody.
I'm pretty excited. I'm going to have a t-shirt, You're going
to have a t-shirt.
I am. I'm going to have a t-shirt. I'm going to be wearing, I'm going to take a picture and put it up on our Twitter.
Perfect. Perfect.
You talked about your t-shirt, but you also talked about your new baby. So I wasn't going to bring it up. So congratulations.
Thank you.
I'm glad you did. I think that's another thing. We talk about the why, and it's not just about, BRI started as Benjamin Rush Society, part of Pacific Research Institute, long before we were 3 or 4 years before we were an independent organization. And back then it was before ACA, and talking about, the Canadian healthcare model, and if that was going to be part of how we were going to turn into the Canadian healthcare model. And then Benjamin Rush Institute was part of the ACA debate on medical school campuses. And now we're turning into where we are after COVID. And it's interesting how the debate changes, and we're following it through with medical school campuses. What are you seeing with DPC practices and what you're doing with these physicians?
Like I said, we've had a lot of physicians who called us up saying, hey, I just lost my job. I've been a doctor here for 25 years. I was addicted to my salary. I thought that I had the ultimate security in a paycheck. And guess what? Paychecks can disappear tomorrow. Then I say that same conversation, hey, doc, how would you like to be in control of your own revenue, your own paycheck? You're paying yourself, you're owning your own business. To my knowledge, there have been a handful of DPC practices that have failed during the pandemic. There's an asterisk, there's a caveat, in that these practices, in the quest to get 500 patients, 500 members of their practice, because that's all they need, right? Very small patient panels, very close relationships. They took on about 85%, 75 to 85% of their patient panel was from big employers locally. And so when the employer benefit options changed, it just sucked the life out of their practice, and they didn't have any more patients because they took them away. Yeah. So we focus on the retail patient, like we call them, people walking in of their own volition, joining their own practices. So from the standpoint where physicians, their offices on an insurance-based practice were basically shut down for 2 or 3 months, whatever it was, depending on what state it was. For us in Indiana, it started basically St. Patrick's Day, and it opened up about July-ish, August. Those doctors didn't have anything to do. And that's when they started getting the pink slips, right? Because the hospitals were down and they're laying off massive amount of patients. It was interesting when we were delivering the baby, the birth center, which was fantastic, just amazing people that worked there, right? They said they lost about a quarter of their workforce due to the pandemic and due to the revenue just drying up. And so it really illustrates a couple of things that drive revenue for hospitals. Elective surgery is a huge, huge driver. I've seen upwards of 60% of hospital revenue comes from elective surgeries. And again, that's why I talked about that needing a second opinion and how there might be a conflict of interest if physicians are just referring up the pipeline and keeping in the same hospital, keeping the same network. Because somebody up there knows that, if we get 10 people who are taking up physician time and exam room time, triage time, and our doctors are saying, nope, nobody needs surgery, that's a lot of money that is leaving the hospital, unfortunately. So don't want to go out and say that all hospitals function like this, but a lot of them, as seen by this pandemic, a lot of them do. And then when we talk about innovation within healthcare and healthcare delivery, one thing I didn't even talk about was a lot of the kind of secret contracts that are signed between prescription companies or PBMs and their hospitals. There are a lot of instances where you have a diabetic and you're prescribing a medication that's 20, 30 years old because it's the generic one and their physicians are barred from prescribing the brand name drugs. We're really going to have a big impact. I mean, medicine and science moves so quickly that you have to keep up with it, let alone the technology to administer and deliver the care that is needed. But when you're talking about prescriptions and drugs, I'm a big fan and proponent of generic medicine when they do work and there's nothing better out there. But to tell physicians that, you are unable to access this medication for your patients because, sorry, that's the contract that we signed.
Absolutely.
I mean, again, it just makes you want to pull your hair out thinking,
Absolutely.
Why are we existing in this environment?
Yeah. And who are you to make that decision? Because, you're not the most trained. You're not the person that went to medical school. You're a bureaucrat sitting behind a desk.
Yeah.
One of our students is early on in the discussion you talked about, and I apologize for not getting to this earlier. You spoke to somebody's heart because you're talking about being in clinicals and only having or being yelled at basically for taking too long. Now, this particular person is also the child of another physician. Yep. And he's saying that his dad had the same story. So he remembers that his dad said the same thing. But so it's been going on for generations that this has been, you're taking too long. So if it was going back in generations, it made me think, how much worse is it now? Because he said that he almost quit medical school. He was in his first clinical rotation, which would have been third year. And he was yelled at for taking too long.
Jeez. It's sad. It really is. And I just want to emphasize, it doesn't have to be this way, right? There are other options out there. The whole insurance as healthcare kind of scheme is it's an unintended consequence from World War II. I mean, it really is. When the government mandated wage controls, employers were fighting for a very limited workforce. And so they started adding healthcare benefits, as we call them now, as a way to entice people to come work in their factories or for their shops. Yep. And from there, it grew and grew and grew. And I love the concept of a community banding together to pitch in and help people out. I mean, that's beautiful. That's what makes us human, right? I don't like the concept of that same community becoming all powerful. And now you are really discriminating against other people who are not part of that community rather than trying to find ways to get the best care for everybody involved or share the risk. So, let's remember that insurance is a financial tool. Health insurance should function just like a homeowner's insurance would. If I need to replace a light bulb, I don't file homeowner's insurance. If my house gets struck by lightning and burns down to avoid financial ruin, that's when I would file my insurance. And so every other insurance product works like that. Unfortunately, health insurance has over the years become this prepaid healthcare plan for many people who don't use it. And it's still very, very expensive. So, going back a couple generations as HMOs and gosh, a litany of alphabet soups and the insurance companies really started to get more and more power, and then sign those secretive contracts restricting networks. And then they expanded the networks. And now we're going back narrow networks. They figured out that to make money off of this, we have to treat people just like they are widgets in some factory. And unfortunately, the more people physicians see, the lower the costs go, does not ring true, right? People, every single person is different. There is no person who is identical, no condition that's going to be treated the exact same way for the exact same duration. When you treat people like an assembly line.
That's not what the codes say though, Chris.
What's that?
The codes, when you put them into the computer, every person's the same.
For a while there, we were doing a Twitter, kind of a Twitter campaign highlighting ridiculous codes. My favorite was hitting the head by a flying duck. That was actually one of them. There was like three or four, maybe like 5 different codes about where in your body you were pecked by a turkey. I am dead serious. It was finger, it was hand, leg, right leg, pecked by a turkey. And I'm sitting here thinking, is this real? Is this what we're asking all of our medical professionals to do with their spare time?
Yes, but it's what these doctors, you don't like the term burnout. It's what these doctors, after working in an office, for instance, they go home and they have to do, and it's what's causing them to leave. I say this story all the time, and people who have been here are probably sick of hearing it. But my 3rd week at BRI, I was down at Duke University hearing a direct primary care physician who I love, Dr. Amy Walsh. She spoke for us, and she told her story after 20 years, tried a lot of different types of medicine, and she walked away. She walked away completely. And she was she had the financial stability to be able to do so. And because she was sick of going home and not paying attention to her family, but instead having to code and code and code. And she was on a family vacation. She was at a conference hotel that her husband was going to in Orlando, and walked through the hotel waiting for her husband, and came across this medical conference. She goes, medical conference, those are my people. Happened to be the DPC conference that you and I, it was a couple of years before that, that you and I met at.
Yeah.
And she had never heard of direct primary care before. 18 months later, she opened her own practice, and she's been doing it, I guess it must be 4 maybe 5 years now. But in that, we're talking to 1st and 2nd year medical students and getting them at this prime time. And she's saying, don't go through what I went through. Learn now, because you can practice medicine before you hate it. And that's what's so important. Is she was real. I mean, she is a stunningly brilliant person, and she hated it.
Yeah, absolutely. And my heart goes out to doctors in her case. But if you look at it, if you're at a school with a teaching hospital attached, there's no way in hell that they're going to talk about other models of care, because they want you to feed into their system.
Yeah, exactly. That's it.
They have a captive audience. And a lot of people, and gosh, the residents and med students are so they're worked harder than anybody I've ever seen. If you're not kind of hit over the head with different types of care models, obviously I love DPC, but there's just some different ones out there, right? Even independent insurance-based practices are out there. They're real. They're still functioning. You're just not exposed to that. So, I would love for a lot of medical schools and even residency programs to have a lot of outreach to DPC practices around as we start to grow this movement. It's still in its infancy. It really is. I'll be the first one to say that, but there are a lot of different options out there, and that'd be fun for a lot of these schools to really, again, want to show their students, get their students the breadth of experiences and really open their eyes to everything out there, and then
that's what we do.
Let them choose.
We bring the that's because we know they're not going to. Right. We're happy to bring those DPC doctors that are willing to do it and bring them to the campuses as much as we can, because they're not there yet. The campuses aren't there yet. One of the questions that came, and I have a few more for you. One of the questions that came in, you were talking about contracts. The student said the contract, the resident, are shoved down their throats. NDAs, do not compete. Do you know of an advocate that will help them read them?
Help them read them? I don't know.
Help them and make those decisions. I think.
Yes. Interpretation. There are a couple of great law firms that we look at. If you wanted somebody legal, I don't think you need an attorney to look at this stuff. You really don't. And ask questions. That would be like the biggest thing. So step one, yes, you have to read it. I don't care if it's 60 pages or 600 pages, you've got to read it. And you have to look at certain things like signing bonuses and the bonus stipulations around that, because usually the signing bonus isn't quite the signing bonus when you get into it. You have to look at what is expected of you. And you have to look at, if this does not work out, what are my options? Do I have recourse to come after my employer for doing some crazy stuff? And there are some crazy things. I interviewed a physician who left a hospital and they were still using her signature as a chief resident to order prescriptions when she was gone. And so it's really a form of identity theft. And then she got in hot water with Medicare once Medicare found out, when she tried to come back into the state. And so there's real life horror stories like this. So you have to read it, pay attention to the bonuses, any stipulations, any clauses that are tied to money, are tied to length of practice, and that are tied to any type of non-competes. I would say that non-solicitation is a very normal thing, and that's the easiest thing to swallow. Basically, if you leave, you're not going to say, hey, patient, I invite you to come to my new practice, or I'm going to this hospital system, come follow me. But the non-competes are absolutely ridiculous. And if you bring that up to somebody and you get pushback, bring up the continuity of care. Say that if I establish care with a patient, and I need to make sure that I am taking care of them, or else this goes against the oath that I took, right? Talk about your Hippocratic oath, talk about your ethics, talk about your morals, and always establish it from the patient standpoint. That's probably one of the biggest mistakes that I see people who, we'll get a phone call from somebody who's in DPC or independent medicine and saying, Chris, I'm struggling, help me out here. And I ask, what's your sales pitch? Why did you do this? What was your motivation? And they say, oh, well, I was burnt out. I wanted to do this. I did this, blah, 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 me. Nobody cares, right? When you're talking to a patient who's just been diagnosed with cancer, they don't care how stressed you are. They should, right? But they have other things on their mind. So you have to approach everything from the patient standpoint. And, if this isn't working, then social media is a very powerful force right now. I wish more physicians were active in social media. Some contracts forbid social media accounts. Seriously, like that happens. I've seen a lot of them that say, hey, my employer doesn't even let me have a Facebook page or, a LinkedIn page. And so again, you're keeping your professional network and your social network all within one system. It's like a closed loop. What else would you know within that? But, if they're playing hardball, or if they say, hey, too bad, then, you might have to fight it, might have to expose it a little bit, but definitely read it. Again, if you need some second opinions or some interpretation, I'm happy to help out. If you need somebody to kind of look at this and say, yeah, this is ridiculous. I'm a big fan of no non-competes whatsoever. There are a couple states out there that forbid non-competes in any industry. In all 50 states, I believe, it's illegal for attorneys to have non-competes. But so I'm like, well, why is that? These are the people writing the laws most of the time, but then they bind up doctors, and it's like, it's so transparent and just kind of slimy is really what you feel like. But more to the point, or point of the story, read your contract, please read your contract. And then know that you have other options. You have an incredible skill set and you will find a job, or you can start up your own practice, but your skills and talents are very much in demand. You don't have to take the first offer that comes your way.
Yeah.
And most of the time, if they throw a bunch of money at you, there are stipulations tied to that. And I'd be very, very careful of accepting those type of agreements.
Yeah. And I think that's something that we're trying to caution the students on as much as possible. Is we know that you have medical school debt, but let's see where that money's coming from so that you're making the right choices for your future. We talk about this question a lot, especially with people that aren't as familiar with the direct pay model and how that works. And for those of you that have joined us on a couple of these, you might know I asked this question and answer the question quite a bit as well. The difference between direct pay, you're talking about the term independent physician. I don't think that's one that we have used before here. So what do you consider the independent physician, direct pay, concierge medicine? How would you define, where would you put all of those in one line?
I would say that they're not linear by any means. When I say independent physician, what I mean is a doctor who's not beholden to some other employer, right? This is an individual who is in private practice. They are the business owner. It's their LLC, and they're taking care of their patients and making the most informed decisions for them. Independent physicians come in all kinds of forms and shapes. There are concierge independent physicians, there are DPC independent physicians, and there are independent physicians that do accept insurance still. There are hybrid people who have kind of a membership plan, but still accept some insurance too. So independent is kind of a category, I would say. And then the DPC concierge would fall underneath that. A DPC is, and again, I'm sure somebody has talked about this, but there's no insurance involvement whatsoever. I say involvement. Some people might say interference. There's no interference or involvement from insurance plans whatsoever. It is usually lower cost, less than $100 a month, about 500 patients, members, paying you for your expertise and for your time. No barriers to care. So we are advocates of no copays, no visit fees, anything like that. If somebody wants to pay you $100 a month to access, what's up here, let them do that. Let them do that. On the concierge side, they're kind of cousins. So DPC and concierge are kind of cousins to each other. Concierge, you're still doing more of a membership, but you're also filing insurance. So a lot of these are Medicare heavy type of practices. The way that they are able to get around that is that they perform what they call executive physicals. So they have to provide a service that Medicare does not cover in order for them to charge an extra fee on top of that. Because Medicare is very clear that if you are accepting Medicare and you charge prices that are lower than what Medicare reimburses, that is considered to be Medicare fraud. And so I brought up the example of a client in Minneapolis that wanted to take care of a lot of pro bono people, and we had him opted out of Medicare almost immediately when he wanted to do that, or else he wouldn't have been able to take care of those people without committing Medicare fraud.
Interesting. I wasn't aware that was what the barrier was. So yeah, that's great. So
obviously we're big DPC advocates, Rebecca, but we look at DPC as going around the minefield of CMS, Medicare, Medicaid, and insurance practices. Concierge is similar, but they're kind of tiptoeing around the mines.
Yeah.
And then, to be full-blown insurance and employed medicine is you're just blindly walking through the minefield waiting for something to hit.
And it does all the time, which I think is what I think we've had the conversation on Twitter quite a bit, especially at the early part of COVID. Our DPC friends giving a lot of advice to other primary care doctors about telemedicine. And it was I don't want to say funny, but it was kind of we told you so, that we've been doing this forever. It's part of our practice. It is what we do. This is how you service the people that you are helping. You have to do this. it was just kind of an interesting to follow along with those people, with the people in our world, the DPC doctors that are already doing this, and them saying, we're spending a lot of time helping other people, but we're helping other physicians, we're helping other practices because they don't know how to do this. Even getting them up on the right, secure lines on Doxy and things like that. It's been, it was interesting to follow that, and now following along with CMS and seeing, if they're going to be truly accepting, DPC as part of what they're doing. I just think it's going to be an interesting next maybe 6, 7, 8 months. I mean, we have to take away the election, but to see what happens. We're not going to talk about that part, but to see what happens with the DPC model and with regulations that go forward. So
yeah, and we get that question a lot. That kind of what I heard there is, is the election relevant? Is DPC in trouble if the election or politics go one way or the other? And I don't think so. You brought up the Canadian healthcare system a while ago, and same thing with the UK and the NHS. There are parallel privatized systems that run with this. More so in Great Britain rather than in Canada. Yeah. But a lot of physicians who are done with that type of nanny state, I'll call it, they go into what's called occupational medicine in Canada, and they just work with employers on their workers' comp and that type of stuff. Or they try to emigrate to the United States to practice medicine, specifically in the DVC model. Talked to a lot of them who are like, hey, is anybody hiring? And we're just like, we're not there yet. Doctors are still trying to build up demand.
Plus, they're taking all the residents in that might be doing this. So
yeah, there you go. There you go. So I think the biggest fear from a political standpoint is if they nationalize medical licensing.
Yep.
If they say you have to accept Medicare to be a licensed physician in the United States, that would be a very, very sad day for a lot of reasons, not just our industry or patient care or physicians, but if they say every doctor is now a government worker, that's tough.
And it's why one of the things that we are, we're big at building advocates. We're trying to inform our students that when they get their MD/DOs after their names, they become bigger advocates for their profession, and teaching them there's multiple ways to do that. They don't have to go out and picket. They don't have to go out and yell loud, but writing an op-ed and even talking to their patients as they want, or their networks. That's wildly important because it is their profession. It is their way of life. And once they get those letters after their name, they are enormous advocates and powerful advocates.
Absolutely. And, we're in Indiana's 5th congressional district, and we have a very hotly contested, political race going on right now. And the candidate, her name is Victoria Spartz, who is very much for transparency in medicine. And I've worked with her a lot on the state level to get different things passed. One thing we tried to pass, and I was working with her closely on, was abolishing physician non-competes, and didn't quite get it, but we're going to keep trying it. So, when she announced that she's running for Congress, I said, I'm going to get you in front of an audience of DPC physicians so you can talk about this. And that's exactly what she said. She goes, there are so many things happening in healthcare that the physician voices are silent on. And she goes, everybody in this room, and she's talking about a group of a dozen or 20 doctors. We have some people who are virtual from different states who are interested in it. She goes, everybody needs to get involved, whether, a yard sign, but like you said, writing articles, not just fundraising, because everybody thinks that being involved in politics is just stroking a check. Keep it civil. If you're one of these people who want to debate politics on social media, it's not my speed, but get involved in politics. Go, try to set some of these things up and help these people, because without your voices, there are going to be people there who are making that decision for you. And that's going to be a big impact. And usually it is the wrong decision that negatively affects a lot of medical professionals, not just physicians, but even nurses and their staff all the way through. It just puts more and more burden or blame in some points onto physicians, and you got to be involved. You have to be absolutely active in politics. So I completely agree.
And, BRI, we help educate, bringing together people like you. And again, I'm going to plug your podcast because I think it's great. Healthcare Americana. Follow them on Twitter as well. If you are active or even just an inactive person, which I know there's plenty out there. Really great content. So I congratulate you on that. I'm going to put up Christopher's contact information. You can always contact me as well, and I'll be happy to put you in contact with him. Freedom Healthworks is the company. Very good business. When you are looking to, even if you already have a business, a practice that you're looking for business advice on, but if you are one of the students that we're talking about and you're looking for that step, because there are so many of us so many of you that have talked to me about that might be the avenue that you're taking, whether immediately after residency or a few years after. I definitely recommend that you at least talk to Chris or one of his colleagues, because 5 years ago it was one thing. Now, as there's more and more practices out there, there are people like Christopher and Freedom Healthworks to help you out. So I can put all of his contact information up after this, and you can always contact me and I'll put you in touch. Chris, thank you so much. Congratulations on the baby. And I'm glad I'm getting a t-shirt. So,
absolutely.
You have any last words before I let you go?
Oh, read your contracts. read them all.
I like it. I think that's great.
Yeah. And you know what, even if you have to fight them on some of those contracts, don't be afraid to fight. Don't be afraid to go in there a little full of piss and vinegar and ready to knock some heads around, because this is your livelihood. And again, if you are not an advocate for yourself and for your profession, who will be?
There you go. Okay.
All right, Rebecca,
thank you very
so much.
Stay tuned, because we will have many more live webinars to go, live event series to go. Our students are back in session, and they are starting to host both live and many more virtual events as COVID continues. But we are going to continue our national live event series. So stay tuned both on social media and in your inbox for our newsletter to announce all of those. So thank you so much, Chris, and thank you all for joining us.
I hope you enjoyed today's edition of the Benjamin Rush Institute's Virtual Events Series. To learn more about our educational programs and events just like the Virtual Events Series, I encourage you to visit our website. While you're there, you can subscribe to the Benjamin Rush Institute's YouTube channel and link not only to all episodes in this series, but also to all of our past meetings, events, and conferences. And please consider supporting our work on behalf of the medical students we serve by donating to our efforts. Your support is vital if we are to continue to provide important educational programs and events just like this one. We appreciate your support, and please watch for your invitation to the next edition of the Benjamin Rush Institute's Virtual Events Series.